Good evening, everyone. I would like to once again welcome you for the part two of Clinical Applications of Neuroplasticity webinar by Dr. Karthik R. Rao. We welcome you, Dr. Karthik.
Thank you. Thank you very much, Dr. Harpreet. And let's go for the second part of this discussion on neuroplasticity. I hope all of you have attended the previous webinar. And for those of you who have not attended this, I would recommend that you watch the part one on YouTube before we continue with this discussion. I'm sure that will give you the background and help us understand the plasticity better. So moving forward, so let's look into the different aspects of neuroplasticity and how it can help us in our day-to-day practice. So we look at, in the first version, we looked at different types of plasticity where we talked about developmental plasticity as well as experience-dependent plasticity. Today, we are going to talk about maladaptive plasticity as well. So not everything is nice and green about plasticity because as we had discussed earlier, it is a mold, right? It's just like plastic, the brain is also moldable. And so which means whatever is the impression that we are giving, what is the experience the patient is getting, that is going to reflect into the actual practice. So which means that the plasticity can also have negative consequences if the negative experiences are built in the patient's experience, right? So when you look at this, the first classical example is that of phantom limb pain, because here what happens is the limb had a representation in the brain. We saw that in the first part as well. And when the limb is gone, it's no longer there. Now that part of the brain is still active for some time, right? And now the adjacent area for that limb, most commonly it is the face area in the brain. And so when somebody touches the face, that area actually gets expands and it occupies some of the space for the lower limb. And what happens is for somebody who had an amputation of the leg, and when there's a touch on the face, there's immediately a correlation with the leg, and the patient starts feeling the presence of the limb, of the phantom limb. And sometimes it also leads to pain in the phantom limb. So this is an aberration that can be seen the central nervous system level. In the peripheral nervous system, we also see synkinesis. Synkinesis is most often seen as a complication of um, very good therapy and too much of exercises, especially in Bell's palsy, where the person is trying very hard to get into those exercises, and you can see that it has an impact on the movement. So let me play this video for you. You can clearly see when the patient is trying to blink, you can see the simultaneous movement is happening on the around the cheeks as well, especially on the left side. So this is a classical example of synkinesis, and commonly it is attributed to aberrant sprouting. So a neuron at the time of recovery is giving a branch to another muscle which it was not supposed to be supplying. Chronic pain is also considered to be one of the aspects of maladaptive plasticity because we know acute pain is most often because of tissue injury. Okay, it can be a fracture, it can be ligamentous injury, it can be muscle strain or cut, whatever it is. But all these tissues eventually heal, right? But why is somebody having pain for 2 years? Because even a fracture in the lower limb heals in 3 months. So somebody's having pain for 2 years, for 5 years. And what happens in this condition is that the brain becomes sensitive, extremely sensitive to pain, and starts feeling certain situation as threat and starts producing pain as a defensive mechanism. So the pain is actually not coming from the affected part of the body like your low back, but it is actually coming from the brain. So it's more aberration of the brain here. Similarly, different forms of addiction is also as an example of maladaptive plasticity. So going back, which of the following factors is identified as a major inhibitor of neuroplasticity? For you to answer this, you should have seen the first part of the video. So there are four options: chronic stress, novelty and challenge, aerobic exercise, and quality of sleep. So let me just give you a few seconds to answer these questions. And this option, you can put the options A, B, C, or D in the chat box. And then let's have a look at the answer. Thank you. And the answer is chronic stress. So we looked at different uh, facilitators and inhibitors of plasticity. So where all the other three actually help in uh, positive regaining of those movements and motor control, whereas chronic stress adds or inhibits the neuroplasticity. Aberrant axonal sprouting in the peripheral nervous system commonly leads to which form of maladaptive plasticity? We looked at different types of maladaptive plasticity. Here we're talking about axonal sprouting, aberrant axonal sprouting. So the options are cross-modal plasticity, phantom limb, synkinesis, and long-term potentiation. So which of these? You can just mention that in the chat box again as A, B, C, or D. Let me give you a few seconds again, and let's look at what is your answer. And the answer is synkinesis. Remember, at the cortical level, at the central nervous system, it's more of cortical remapping is happening. At the peripheral nervous system level, it is more of axonal sprouting. So that brings us to the next part of the discussion about active learning and passive learning, and where does neuroplasticity have a bigger role? Now, naturally, you can say active learning, the patient is more active, he's participating, and therefore the plastic changes are likely to be better. So let's understand this with a few more logic as well and some neuroscience. So when we actually do a movement, the corticospinal tract originates from the primary motor cortex. And so when a movement is initiated, the stimulus from the primary motor cortex goes via the, so let me choose color here. So from the primary motor cortex, we have inputs which goes to the spinal cord, and from the spinal cord, it goes to the muscles as it is shown in this particular picture. Okay, and parallelly, we also have an information which goes to the cerebellum. Okay, this information which goes to the cerebellum is called as the efferent copy or a corollary discharge. Corollary means a parallel discharge. So the information which goes to the muscle is actually a motor command. You have to contract, you have to bend your elbow or bend your fingers. So that is a motor command. Whereas when it comes to the cerebellum, it is a copy. It tells the cerebellum that I have asked the elbow to bend or the biceps to contract. So that kind of information goes to the cerebellum. So this happens only when there is a motor command initiated by the patient themselves. Okay, so now let's look at what happens after that. Once the motor command is initiated, the feedback goes from the muscle, like you can see in the green color, and it goes to the spinal cord, it goes to the cerebellum. Of course, it also goes to the parietal lobe for the somatosensory cortex. And here, now the cerebellum has two information. Okay, so what is this information called? The first information was called as the afferent copy, and this information is called as the first information of the efferent copy, and this information is the afferent copy. Okay, afferent, ascending, so it's sensory, so it's a proprioceptive feedback, right? Now, what is happening here is that the cerebellum has two sets of information. One is the intended movement, which comes from the motor cortex, and one is the actual movement, which comes from the muscles. Now, when I naturally have two information, the natural thing to do would be to compare. Okay, and when I compare, I find that they are matching or they are not matching. So when they are matching, it's all well and good. But when they are not matching, I do something called as error detection. So I identify there is a mistake, something is wrong somewhere. And then the cerebellum is going to feed this information back to the primary motor cortex and say that last time you had given 30 units of command to the muscle to hold this water bottle, and the muscle was trying to hold it and it was not sufficient, it slipped off, and so this time you have to give 50 units of signal to hold the bottle firmly, right? So that is the learning. So this learning, a key component to this learning is the error detection, and this error detection can happen only when the cerebellum has both the information and it can compare the intended movement versus the actual movement. Now, what happens in a uh, passive learning? It could be a passive movement, it could be passive stimulation, or any other modality where the patient is not initiating the movement. Is the first thing is that there is no motor command which comes from the primary motor cortex to the spinal cord or the muscle, right? And therefore, there is no efferent copy. The cerebellum does not have any inputs from the primary motor cortex, so it does not know what is the intended movement. Now, when the muscle, because you're passively moving a muscle, there is some stimulation, some contraction of the muscles happening. So that is going to go back to the spinal cord and to the cerebellum. And the cerebellum, this is still receives that information, which is the afferent copy, but there's no efferent copy. And so there is no error detection. So if there is no error detection, there is no learning, and therefore the cerebellum cannot go back to the cortex and give the refined input. And so in the entire process, the problem solving ability of the person or of the brain goes for a toss. Okay. While I'm not saying that stimulation should not be given or passive movement should not be done, because these have their own advantages and their own patient segment as well. If the patient is flaccid or the patient is not able to move by themselves and we have to maintain the joint range of motion. So there are some objectives why we do this. But the idea here is the active brain is very important for learning a new movement, and the initiation should come from the patient's own primary motor cortex. So the feedback then becomes very important. So now what is an error detection? Error, essentially, I know that I have made a mistake. So what is that mistake coming from? It comes from a feedback, right? So I was trying to hold it and it fell down. So that's a feedback from me. So the right feedback is very important for error detection. And only when I detect what is wrong, I'm able to self-correct. And once I self-correct, I practice that, and then I get spontaneous, good quality movements. And whereas inadequate feedback leads to no error detection, because I don't know what I'm doing is right or wrong. So I'm not going to correct myself, but I still continue to do that, right? So a person with, let's say, a circumduction gait is going to continue walking that way without knowing that this is not the right way of walking, or he thinks he's doing the right way of the walking the right way. Then he's going to continue doing that. So the practice and repetition is still going to be there, and it's going to lead to effortful compensatory movements. So if I compare active versus passive learning, active learning is where it's a top-down approach. It starts from the brain. And here, higher levels of attention is a primary driver for neuroplasticity, because the patient is actively looking at it and problem solving. And then is highly effective when there are traces of muscle activity. So this is where we get into surface EMG biofeedback, where we use this to give the right feedback to the patient. And this comes into the picture only when there is a mild amount of or any trace of muscle activity is present. So many times passive learning is ideally suited when there is zero muscle power and the device or the external force, or it could also be a therapist who's doing a passive movement, takes over. When it comes to precision, when the patient is actively doing something, they're also addressing the compensatory movement strategies, because when I try to do a movement and then instead of muscle A, I'm using muscle B, and then here the person gets a feedback and then they're trying to correct that as well. But in a passive learning, that is not addressed. And when we talk about grading of motor units, now we know that we don't apply the same amount of force for everything. If I'm taking a ceramic cup versus a disposable cup, a plastic or a disposable cup, then I'm not going to use the same amount of force. And this can happen only with an active learning module. Whereas if it is completely passive, it's always a mass recruitment of motor units, and therefore grading is not possible. And finally, when you're doing something actively, it becomes easy to transfer. We also looked at this from the principles of experience-dependent plasticity, where we talked about transference. And here, it's easier to transfer because the brain has actually initiated the movement. The brain is perceiving and saying that if I can do this, a similar task like this, I can do, right? So it becomes easy for the brain to transfer to functional task, and then there is no dependency on the device here because the brain is the initiator and not the device. And many times we see with passive learning that there's a machine dependency. As long as the patient is on the particular device, they're able to move around, and it looks like they're learning a new skill. The moment that device is withdrawn, you can clearly see the difference between the night and the day. So one of the very popular approaches or theories of motor learning is the Fitz and Posner's model of motor learning, which talks about three stages of learning. So there is a cognitive stage, the associative stage, and autonomous stage. So let's take the example of how learning to drive a car. Okay, the cognitive stage would mean that I understand the demands of the task, which is the clutch, gear, the brakes, and the steering, how to operate the steering wheel, uh, and all of that would be the cognitive stage. So you understand the theory of and the expectations, and then you start practicing it. And then you get to the associative stage where you learn how to drive, but you're not very confident. So probably you will drive only during the day. You'll probably have somebody who is sitting next to you who knows driving. You're not ready to use GPS or listen to songs or talk to somebody on phone. So that is the associative stage. And you'll also choose your familiar routes as well. Maybe you'll choose it during the day where the traffic is also less, or you'll restrict yourself to only to familiar routes as well. The autonomous stage comes when you start using the Google Maps. Then you just look at the map. If you go to you go outstation, and some spontaneously you're able to change gears. You do without thinking much about it. You're able to apply brakes when it's required. And this is when we talk about muscle memory, right? What is muscle memory? Essentially, is you do an action, you do a task without even thinking about it, right? So when you apply brakes, you change the gear, okay, subconsciously, and that is where the neuroplasticity is actually complete, right? Because now the connection which was established in the cognitive stage slowly became stronger and stronger in the associative stage. At the autonomous stage, the connection is firmly established and it has become part of your daily routine. So any learning will go through these stages. And that brings us to the reinforcement corner. So the question here is, when the primary motor cortex sends a command to muscles, what signal is simultaneously dispatched to the cerebellum? Okay, so what information goes to the cerebellum and what is it called? Is it synaptic pruning signal, if efferent copy, or the corollary discharge, distinct potential, or the afferent copy? So I would like to request you to put your answers in the chat box. So we have four options: A, B, C, and D. You can just mention the options, and let me give you a few seconds to key in your answers. Yeah, thank you so much. Let's look at the answer. The answer is efferent copy or corollary discharge. So now the cerebellum gets a copy of this message about the intended movement. So now let's look at some common mistakes done by PTs, primarily with novice PTs who have all the right intentions, but somewhere uh, they have practiced a few things by themselves. And so I wanted to add this point where what is the common practice and how it should not be done. Okay, too many times we see shoulder as a painful shoulder is a very common complication of hemiparesis, and and I still see a lot of patient therapists who still use passive movement for uh, patient care. While passive movement has its advantages, we have discussed it about that already to maintain the range and muscle properties to some extent. But what is important for us to remember that the shoulder is not an isolated. It's not just restricted to the acromion and the head of humerus, right? It is you have the scapula is also part of that, right? So you have something called as the scapulohumeral rhythm, right? Which means that if I move the shoulder, the scapula also moves out, upwards, and sideways depending on the task. And so any movement in the shoulder is usually accompanied by the scapula as well. And therefore, when you do a passive movement, many times we restrict or we do the movements only for the shoulder without considering the scapula. And when you do a passive movement or when you passively mobilize the shoulder joint, always consider the scapula as well and move it according to the biomechanical principles. Similarly, looking at using weights for straightening the limb. So too many times I've seen that the therapist, with all good intentions, they use weights to straighten a limb. So let me say something. For example, if my biceps is spastic, right, and I use a 3 kg weight and place it on the limb, and then I can see that the patient is able to keep the limb straighter. Is that a good strategy? Not so. Why? Because the moment you use weight on the limb, the person instead of actually relaxing the biceps is going to activate, because the weight is going to act as a resistance. Now we know that when a muscle has to work against a resistance, the muscles become stronger, right? So here, by using or introducing weight, even though you may see that the range has improved for as long as the person is wearing that particular weight, you can clearly find that you're instead of uh, relaxing the biceps, in this case, you're actually strengthening the biceps, and this is going to be counterproductive. So do not use weights to straighten the limb. And we discussed about this in the first part as well. Adequate challenge has to be given. We can't be too soft on patients and keep them in the comfort zone and expect them to meet the goals that we have set for them. And many times the goals are very generic. We have to be much more specific. We can probably have a discussion around how to write a goal and the impact of and how to choose a goal. So those can be a separate topic in itself. But we discussed that when you have a goal, be very specific that I would want the person to be able to stand for 30 seconds or to walk 10 steps, right? So when you have a measurable goal, it becomes easy for everyone concerned. It becomes easy for the patient to understand, to the caregiver, and to you as a therapist. And if you're transferring this patient to another therapist, they also understand this is the goal that I'm working towards. And at the end of that predefined period, whether it is 1 month or 3 months, you will know whether the goal has been achieved or not. And focusing only on strength training. So I do see that as a very common phenomenon, because we do so many exercises during a session that the focus largely goes into strength training. So let me just give you this example. All of us know our champion Virat Kohli, and so he is doing something to the gym. Right? So he's lifting a weight, which probably is good for his shoulders, strengthening his core as well, right? And do you think that by doing this day in and day out, he's going to become a better cricketer? Definitely, his shots will be more powerful when his muscles are stronger, right? But does it translate into skill? Does it make him a better cricketer? And I'm sure, like all the cricketers or any athletes, will spend time in the gym to strengthen the muscles and to condition their muscles. But what is also important is the skill, which happens within a context. So here we can clearly see that our therapy should not just focus on the exercises, but it should also focus on the skill level, whether it is reaching, picking up objects, or opening something, closing something, typing, writing, drinking, right? So these are certain skills that have to be taught within a context that is important, and is very important for, especially for in a neuro rehab session. So overall, the focus should be a combination of strength training along with skill training. So with that, we come to the end of this discussion. And I would like to thank you all for your patient listening and for actively participating in the chat and answering those questions as well. I'll be happy to take in any questions here. Thank you so much.
Thank you, Dr. Karthik.
Thank you.
On behalf of Neurophysiotherapy India, I extend my sincere gratitude for taking time to share your valuable knowledge with us. And I hope that the participant found today's webinar informative and clinically relevant. Once again, thank you everyone for joining us and interacting at appropriate times. We wish you all a wonderful evening and look forward to seeing you at our next webinar. Take
Yeah,
care.
thank you, sir. Like, I would also like to thank you for inviting me and giving me this opportunity. And thank you for the Neurophysiotherapy group as well as all the participants for active participation. Thanks a lot.
Thank you, sir.